session covers two topics we haven't talked about yet, and I'm very thrilled to have these two people here to talk about these topics. Dr. Jill Johnson is an associate member of the Bloodworks Northwest Research Institute and associate professor at University of Washington in Seattle. Dr. Johnson's research is focused on inherited bleeding and clotting disorders such as von Willebrand hemophilia and pregnancy-related vascular complications. We also have with us Dr. Judy Sims-Senden, and she is the founding division director of pediatric adolescent gynecology at the University of Miami Miller School of Medicine, OBGYN department. Dr. Senden has worked extensively with adolescents with bleeding disorders and has written national guidelines for care of adolescents with heavy menses and bleeding disorders. And I'd like to welcome them both to the stage.
I'm delighted to be here. I hope everybody can see the slides and hear me okay. I'm looking at the chat. Perfect, I can see it. So I am thrilled to be here at this presentation. I have really enjoyed every opportunity I have had to work with women with bleeding disorders. And I'm not very shy. So at the end of the presentation, especially at the end of Jill's presentation, which is when we're going to open it up for questions, please throw them at us. We love to be a resource. So what I'm going to cover today is recognizing causes of abnormal bleeding when I'm not pregnant. So for an example, I saw a patient just this month. She's a 13-year-old with known factor VII deficiency who came to my clinic for help with her really heavy periods. She had been having regular periods lasting 5 days, and they weren't too heavy for the first 6 months, which is really great given that she had a bleeding disorder. She then skipped a few periods and then had really prolonged bleeding lasting 4 weeks. And was that bleeding that lasted for 4 weeks really from her bleeding disorder? Or was there something else going on? And I bring this up because I think it's important to recognize that women with bleeding disorders have everything else that women without bleeding disorders have. They just bleed even more when something goes awry. So, next slide. Okay, so I want to first cover what happens in your regular normal menstrual cycle. Here's a cartoon of your menstrual cycle. I love these evil guys up here, but I think it's fun. So at the start of the menstrual cycle, which is basically the first day of your last menstrual period, actually, which is represented by this bleeding down here, your brain wakes up and sends messages down to your ovary telling one of your eggs to get ready and to have some of the little cells around that egg to start making estrogen. And that estrogen rises and builds up a lining inside your uterus. That estrogen level gets up high enough and tells your brain, sweet, that amount of estrogen means there's a perfect lining to have a baby. So your brain sends this pretty strong signal down called LH that tells you to pop out one of those eggs. And for some women, this can be actually pretty painful. Some women don't even notice when they ovulate. And then after you ovulate, where that egg was, you make this hormone called progesterone that keeps building up this lining, making it ready for an implanted egg or pregnancy. And it keeps building it up and building it up. But if you don't get pregnant, about 12 to 14 days after you ovulate, your ovary says, I guess I'm not needed anymore. And your hormone levels drop off. And when that happens, you start to shear off the lining of the uterus where all these little blood vessels called your spiral arterioles are. Well, if you don't have a bleeding disorder, no big deal. These blood vessels will form a clot inside of them. But with a bleeding disorder, you can bleed extra heavily. Why? Because you don't clot normally where some of these blood vessels are open, and it allows more to escape. And that's basically the heavy bleeding. So what actually is a normal amount of bleeding? Because for someone with bleeding disorders, it's all been heavy all the time. A normal amount of bleeding is about 3 to 6 pads a day for 2 to 8 days. And your cycles, as I mentioned, start from the first day of the last menstrual period to the first day of your next period. So here's a 27-day cycle. So in general, 27-day cycles, anywhere between 25 and 35 days can be normal for some women. And what is too much bleeding? Whatever you say is too much bleeding. And actually the definitions have gotten looser over time. What do we consider really heavy menstrual bleeding? Technically, though, it's greater than 80 cc's of blood loss. Now, who on earth actually keeps track of what 80 cc's really looks like? Well, if you've got one of the menstrual cups, you can see it. But usually that's bleeding through more than 5 pads per day, bleeding for longer than 7 days, flooding or gushing blood that limits your daily activities or school or exercise. And for my teen patients that I take care of, they have had episodes where they're just mortified when they flood through their clothes at school. So, really controlling that is very important to me. Passing clots bigger than a quarter, changing a tampon or pad every hour or less, or having iron deficiency anemia because all those little red blood cells have come out on your pad. If you have periods and you're not using a period tracker app yet, and don't have your personal favorite, my personal favorite that I recommend is one called Clue, which is a period tracker. Why do I like Clue? It's developed by nonprofits like Stanford and Oxford and some of the institutions there, and it doesn't send your information to the internet, which to me is really important. Some of the other tracker apps will actually send information, and you might even get pop-up ads like, oh, do you need to buy pads because you're on your period? I mean, to me, that is TMI. Nobody should see when I get my cycles. So Clue period tracker app. And then a few other things. There are so many options out there. I know this is a conference for teens all the way through adults, but back in the day, there were just pads. And then we got fancy and we had tampons, thank God. But for those of you who aren't comfortable with either of those, there's underwear, period panties, and they come being made by many different people, not just Thinx, but Thinx are really awesome. Menstrual cups, which are absolutely safe, that come in all different shapes and sizes to make periods much more doable. Okay, sorry, going the wrong way. There we go. So why do we recommend as gynecologists various birth control methods to decrease bleeding for women with bleeding disorders? Well, all methods of birth control contain a progesterone form called progestin. Progestins are just synthetic progesterones. And while progesterone that women make naturally make the lining a little bit thicker so we can implant a pregnancy, progestins actually are stronger and make the lining really thin. And they can be used continuously so women don't actually shed a lining, so you don't get the progesterone drop. And they're really effective to decrease bleeding with cycles. And you can use them in the forms of pills. You can use them in the form of Depo-Provera. And this is one of my own personal favorites. This is a little Mirena IUD. It's about the size of a paperclip. And it's been shown to be super effective in women with bleeding disorders as well to decrease the amount of bleeding that women have. So if we look at what are some of the reasons women might be having bleeding that aren't just your bleeding disorder, which can cause problems at any point in your life, but what are some of the things that I need to think about as a gynecologist that may cause a woman to have bleeding at different points in her life, in addition to her bleeding disorder? Because again, we're all women and we can end up having all of these. And I'm going to talk about these a little bit more in depth, but one of the most common reasons, and we're going back to our case that I talked about in the beginning of my 13-year-old, is that sometimes we don't ovulate regularly and your hormones can be out of whack. So you can have prolonged periods where you skip periods and then really frequent periods. That also happens again in perimenopausal period. Some people call it the second puberty. Endometriosis can cause people to bleed abnormally, fibroids, and cancer. And there are other reasons, but these are some of the big ones that we see. So I want to touch on them pretty quickly. So ovulation problems mean that the hormone signals going from your brain to your ovary to the uterus are not aligned. And around puberty, what I often say is just like girls sometimes don't listen to their mother, sometimes your brain doesn't listen to your ovaries. And the hormone signals it sends to trigger ovulation just don't work. So what happens is the brain starts to send those signals and we make estrogen, but they miss the signal for ovulation, and we don't make progesterone. So what happens is you start building up a lining and building up a lining and building up a lining. And what happens is it outgrows its blood supply. So you start irregularly shedding little bits at a time. Part of the top of the lining comes out, part of the side of the lining comes out. So you're having these irregular bleeds that are just constant. And then all of a sudden the brain goes, silly me, I was supposed to ovulate, and whoosh, everything comes out at once. And that's when you get these really heavy bleeds of the entire lining. Why do I think, why do I spend so much time on this? Well, oh my gosh, we are seeing so much of this now in so many of our teens because of the pandemic. Why? Because what happened during the pandemic is girls were isolated. They stayed home from school. They didn't sleep well. They missed their friends. They became depressed. And all of that totally wigged out the brain communication system, and girls stopped ovulating. So they ended up skipping periods for a while. Also, rapid weight gain can interfere with ovulation. So you put on a lot of weight, you're not sleeping well. All the COVID pandemic triggered a lot of this. How do we tell if this is really what's going on? Most of the time you can find out in the history, is somebody close to puberty? Is somebody close to menopause? Do they have a bunch of stressors? We can do blood work to check hormone levels. So if somebody's thyroid's not working well, this can also cause women to have abnormal bleeding. The good news is once we figure out that it's really just this anovulation bleeding, women are ovulating, we can use hormones to override the system, to retrain the uterus, to stop shedding irregularly, and to override it all until people, at least for 3 to 5 months, and then stop and see what happens with ovulation again. But birth control pills or other hormones are super effective at treating this and overriding the abnormal lining. Of course, we don't want to just mask or fix the periods and not fix any underlying stressors. We want girls to sleep well. We hope they're doing well in school. We want to fix any problems behind the scenes. Around perimenopause, this can happen to women when the ovaries aren't working as well, the eggs are getting tired, they don't ovulate as often, or a lot of stressors too. I mean, let's face it, perimenopause is a time where we start to have a lot of responsibilities, taking care of elderly parents. Divorce happens around that time. Kids move away from home. There can be job changes. So those same different kind of stressors, but stress in and of itself can also trigger these anovulatory bleeding periods in women around perimenopause. I want to say a few words about endometriosis because I feel, we're going to be studying this at our institution, that endometriosis is underdiagnosed in women with bleeding disorders. Endometriosis is when this lining, the endometrium, grows outside the uterus, or at least outside the cavity. So onto the fallopian tubes, onto the ovary, sometimes it's on the bladder. Adenomyosis, which is what this picture is showing, is a form of it, we think, that where it grows inside the walls of the uterus. And it's a combination of probably backflow of menstrual blood from the uterus that comes into the abdomen, but that happens to almost all women when they're on their periods, but also some inflammation in the pelvis that can cause this to happen. When should you suspect endometriosis? If your periods are really painful, if you're having pelvic pain between your periods, if you're having pain with intercourse, especially deep pain, or if you've been really well controlled on your hormones before, but all of a sudden you're having heavy bleeding and the hormones aren't working anymore, what could be going on? How do we diagnose endometriosis? Well, sometimes we'll be really highly suspicious based on symptoms. Unfortunately, these implants oftentimes are really small, so you can't see it on ultrasound. So laparoscopy, or looking inside, is really the best for diagnosis. Why is it important to treat it, or to at least know what's going on? Is because you can treat the lesion surgically so the pain can get better. And then we really go out of our way to use even stronger medications sometimes for menstrual suppression. After our women are done having children, some women will elect to have a hysterectomy to treat endometriosis, but clearly that is not something I would ever recommend for somebody before they've absolutely completed childbearing, and definitely nothing we'd ever recommend for our teenagers. A few words out there for my teens and adolescent young adults. Infections such as sexually transmitted infections can cause abnormal bleeding. So gross but true, chlamydia and gonorrhea can travel up the cervix and into the uterus, and they irritate the lining and they can cause bleeding. In women with bleeding disorders, things like herpes, which usually just cause blisters on the outside that are painful and miserable, can be really fragile and can also bleed. So be honest with your doctor. We are really good at treating you with respect and confidentially counseling, even teens. We know that people have sex and even have sex outside of their normal relationships. It happens. We would love for you to feel comfortable telling us if you have a new partner and testing for sexually transmitted infections, because these are conditions that can cause scarring your fallopian tubes, cause abnormal bleeding. It's really important to treat. When should you worry about these, again, infections? If you have new bleeding on your birth control pills or other medication that's worked really well for you before, if you have a new discharge that's different than the regular discharge, if you've been sexually active without condoms, please let us know. STI testing is super easy. We can even do it out of urine. We did a lot of sending urine samples without actual exams for people who are afraid to come in during the pandemic. And antibiotics can be really effective at treating gonorrhea and chlamydia, so we can make this better. So just let us know. And of course, my friends, the condoms in every color, yes, and every flavor on the backside, don't have sex without them. Fibroids. Fibroids are another thing that causes abnormal bleeding and usually present in my patients who are older, so women in their 30s and 40s. Rarely there are women in 20s who have fibroids. Usually that's happened in women who have family histories of fibroids. And these are a real problem for women with bleeding disorders as well, because fibroids, while they're benign and they are just these benign growths of just the muscle of the lining of the uterus. This is a uterus that somebody had removed. This is a uterus on an MRI where you can see these fibroids as well. But you see these big blood vessels? Fibroids are blood vessel factories. Oops, sorry. And they increase the blood supply to the lining of the uterus. So you take fibroids and you add, a bleeding disorder, and women can have really heavy periods. If you have a history of fibroids, if you're having really heavy bleeding, like you turn on a faucet and it's gushing, or you're having a lot of pelvic pressure, I don't know why it's doing that, and pain or constipation, because these can get to be big, make sure you tell your doctor. These can really easily be seen on ultrasound. You don't necessarily have to have an MRI. They can also be felt on a physical exam. And while in the past we used to do hysterectomies for women with fibroids, there are other ways to treat this that are less invasive. There's a procedure called uterine artery embolization, where you can thread a catheter into the blood vessels and block off the blood vessel supply to the uterus, and it causes the fibroids to shrink up. So you can avoid sometimes really big surgery. Or if women have fibroids and they really still want to have children and they don't want to have a hysterectomy, you can just remove the fibroids themselves. So there are lots of options out there now that didn't used to be possible. And uterine artery embolization is great for women who have a bleeding disorder and want to have big surgery. Finally, I want to touch briefly on cancer, because these are two things that probably scare us all the most. But the two cancers I'm going to talk about today have come a long way in both prevention, diagnosis, and treatment. So the first one I want to cover is cervical cancer. And the reason why women will present with bleeding when they have cervical cancer is because the cells on the outside of the cervix cause blood vessels to grow. And you can see the cervix, right here has a lot of blood vessel activity there. So you can either erode into a blood vessel, or when women have sex, they can bleed after sex. One of the most important advances in the last 20 years has been human papillomavirus vaccination. And I know that there's been a lot of concern about vaccines raised in general in our country during the COVID pandemic. But we know that HPV vaccination is both safe and incredibly effective. It doesn't have any live virus. It doesn't have any killed virus in it. It's just the outer protein capsule of the virus that is present in that vaccine. And when you give it to a patient or to a woman, she learns how to make antibodies to the capsule of the virus and prevents that virus from infecting. And when women have been vaccinated against HPV, they have much, much lower risk of cervical cancer. And in some countries where they've had full uptake of this vaccine, they've had 90% drop off in cervical cancer cases and even the precancer cervix changes caused by HPV. So I strongly, strongly encourage women to get vaccinated for human papillomavirus, against human papillomavirus. It has nothing to do with sex at this point, and in terms of getting the vaccine, doesn't make people sexually active sooner. It just prevents cancer, and it's so good at that. The second is that women should make sure that they get their pap smear screening with HPV testing, because HPV usually takes 5 to 10 years to cause changes on the cervix. These precancer changes can be detected early and then treated before somebody gets cancer, kind of like how you would treat a cavity before you would lose a tooth. And I say that because I like going to the dentist about as much as everybody else likes going to the gynecologist, but there it is. I do think it's important, and it's a way that we can prevent cancer by finding it early and picking it up. Another cancer that presents with bleeding is endometrial cancer, which is cancer of the lining of the uterus. That usually presents around perimenopause or after menopause. So if you're somebody on this conference who's already been through menopause, God bless you. Isn't it wonderful? You don't have to have periods anymore. But all of a sudden start bleeding, then you have to worry, do you have any abnormal cells inside your uterus that could be causing cancer? So always take seriously, even with a bleeding disorder, any bleeding that happens, especially after menopause. You shouldn't be having bleeding anymore. There are certain things that you can do to actually prevent some kinds of endometrial cancer. Keeping yourself healthy and exercise and keeping your weight healthy is really key to preventing endometrial cancer, because we know that it's caused by excess estrogen that can be made in our fat cells. And women who are overweight have about a 7-fold increased risk of endometrial cancer. So all that good eating healthy and exercise actually is really good at preventing endometrial cancer by keeping you healthy. If you have abnormal bleeding, especially bleeding after sex, bleeding after menopause, make sure you see your doctor. Your doctor can make the diagnosis oftentimes with an exam, an ultrasound, or a biopsy of the lining of the uterus if needed. And these are cancers that can be effectively treated surgically if they're caught early. So it's better to, if you're concerned, make sure you come in and get seen. So in addition to well woman checkups, when should I see an OBGYN? If you're having heavy periods, come see us. We can help. There is no reason to suffer. For bleeding that's irregular, especially between your period, if you're bleeding longer than 7 days, if you're having cramps, pelvic pain outside your period, or have a lot of pelvic pressure, if you need STI screening, if you're bleeding after intercourse or after menopause, we're here to help. And thank you very much. I wanted to make sure we had enough time for questions, so I'm going to pass it on.
Oh, thank you. Okay, it's always weird to speak virtually, so I'm going to give my talk and then really just look forward to having a conversation with everyone. And that was just such a fantastic talk, Judy. So today, I just wanted to make sure I put out my disclosures, but they have no relevance to today's talk. So today we're gonna, this is the outline of what we're gonna talk about, which is sort of general considerations and understanding bleeding in females. And when I say females, I mean persons with the potential to menstruate. It's a biological statement. So females with inherited bleeding disorders, just to get us all reoriented to where we're going in this talk. We're going to talk a lot about genetics and prenatal testing, because pregnancy is biological reproduction and it is informed by our genetics. We're going to talk about what happens to factor changes in pregnancy and in bleeding disorders. Then we're really going to sort of dive into what happens in the pregnancy, what happens around the time of the delivery, We always have a conversation about anesthesia, and then we really want to talk about postpartum hemorrhage and what can we do to try and improve things. So when we talk about rare bleeding disorders today, basically, today's talk is essentially all of them except von Willebrand disease. And I didn't talk much about HHT, but if we want to, or connective tissue disorders, but if we want to have those conversations, we can do that near the end. And in short, there's not a ton of data. So most of this comes from hemophilia, but I'm doing my best to be inclusive, and I'm certainly happy to talk about any of those other disorders at the end. So considerations in females with inherited bleeding disorders. This slide encapsulates some of the key reasons that I think contribute to why this is a really hard space. So we have variable bleeding in a bleeding disorder in general because of penetrance and expressivity being variable. So penetrance is how many individuals who inherited that genotype, that genetics that causes a bleeding disorder. Not everyone who gets that genotype will have bleeding. And then expressivity is not everybody who inherits that genotype has the same amount of bleeding. Some people bleed very heavily, and in the same family, even in siblings where they clearly inherited the same thing, the bleeding phenotype can be very heavy or not so bad. And also we have this sort of, what does it mean to have excessive bleeding in general and considerations in females? It's very difficult to quantify some of this bleeding. Essentially, no one is measuring how much menstrual bleeding they're having. It's very hard to measure postpartum hemorrhage. No idea how to measure an ovary that has had a hemorrhagic rupture. So female reproductive tract bleeding poses unique challenges to that. And we also have these systemic biases because the system defines excessive for one group compared to another by having a comparison group. And we don't have a female reproductive tract not bleeding disorder phenotype. We can't compare to males because they have no chance to have that kind of bleeding anatomically. In addition to all the biases in the system that result in delays in diagnosis, barriers to care, barriers to research, and this audience is very well aware of these things, so I'm not going to spend much time on them. Female hormones can influence some factor levels, so they can directly impact bleeding. And also an additional consideration is that 2 of our inherited bleeding disorders have genes that are on the X chromosome. And so there are inherent differences between males and females simply because it's the difference between 1 X chromosome and 2 X chromosomes where there's 2 copies. So the biology is also tremendously different there. And I would argue that almost everything we know about hemophilia so far has really been defined by males. So talking about this male-centric approach in hemophilia, this is exactly the kind of slide that medical students are shown. Basically, hemophilia, rare X-linked bleeding disorders. Here they are. Hemophilia A, deficiency in factor VIII. Hemophilia B, deficiency in factor IX. What is the bleeding phenotype? It is a bleeding into joints and soft tissues and with traumas and surgeries. And there is nothing here about female reproductive tract bleeding. And additionally, hemophilia severity is defined by the factor level. So we say severe hemophilia is a factor level less than 1%, moderate 1 to 5%, mild more than 5%. And in males, those levels roughly correlate with bleeding. And that is more and more evidence this is not a fair thing to say in females. So we're defining disease severity based upon a level that may be more applicable in males, but really isn't very applicable in females. And so the way we talk about our disorders and the way we define these really matter. And it's going to matter a lot when we come into pregnancy. So let's talk about what we know about levels in females. So we know that female genetic carriers of hemophilia, because they only have 1 copy that's normal of the gene, the whole factor levels are skewed to the lower end, but sort of have the same distribution. And some of those levels meet criteria by just regular level cutoffs to be called hemophilia. But we know that those levels and the bleeding are only roughly correlated. There's a number of references right now that are in some of my later slides, but I wanted to show you this unpublished data from my Life or Future, where we looked at the bleeding scores of people who we knew had 2 X chromosomes relative to the factor levels that they had been reported at baseline. I just want to draw your attention to the fact that if we look, the blue is a level where everyone agrees it's hemophilia, And yellow is where there's, maybe, if it's 40 or 30, but certainly less than 50 is getting, low. And then we look at who has a high BAT score, which is the bleeding assessment test. We see that in all of the categories, hemophilia A and B, there are examples of females where the level is firmly in the normal range, but their bleeding score is high. And this has been seen over and over again at this point in relatively small studies, but we are seeing it, and we all know patients where the level and the bleeding don't correlate. So we have this caveat about factor levels, which is true in many of the other rare bleeding disorders for men and women. And that's because many of these other rare bleeding disorders are what we call autosomal. They're not on the X chromosome. So just wanted a refresher about how this all works. So dominant means you need one copy of a gene, and it can be, it's on a regular autosome. So it doesn't matter what the sex of the parent is who has it, and it doesn't matter what the sex of the child is who inherits it. But 50% of the kids will be affected because it only takes one copy to cause bleeding disorder. A recessive disorder is where both of the parents usually are fine because they have one copy, and one copy isn't enough to cause bleeding. And then you have a 25% chance that a baby will have gotten two copies that cause disease, and only then do you really have a lot of bleeding. I think I have suspicion at this point that we don't have true recessive traits in our bleeding disorder community, but certainly the most severe in recessive disorders are in those who have two copies. And then we have this X-linked inheritance, where we have this common view of what recessive X-linked disorders look like. And hemophilia for many years has been thought to be a recessive X-linked disorder, but we're going to talk about why I don't think it is. This gives you, since some of you are not hemophilia patients or family members, just a view of where we mostly see these disorders lying. And so many are quote unquote recessive. Certainly the most severe forms are with two copies, but some factor 11s or fibrinogen disorders can be dominant. And let's talk about X-linked inheritance real quick. Some of you have seen these slides from me before, but I think it's so important we're going to do it again. This is the cartoon of what many of us have thought X-linked recessive inheritance looked like until we thought about it. So in this, we'd say, oh, the mom is a carrier. She has no condition. Mom has two X chromosomes. She passes one of her X chromosomes on to each time she rolls the dice and has a kid, or she passes on the one that doesn't have a hemophilia causative variant. And so 50% of her kids get this. And then we would say, well, only the males who have only her X chromosome have the condition. So the males have been the primary focus of hemophilia everything for years. And thankfully this is starting to change, but this has we need more work. And the females have really only been tested as the relatives of male disease, and usually only because of reproductive counseling, because they may be at risk to have a male who's affected. And that has been the history. So I think we want to bring this into question. So the first question is, why do we use the word carrier? And in hemophilia, we now colloquially say carrier, and we mean female, but in medical genetics, the definition of a carrier for any condition is an individual who has a disease-causing gene change in one copy of a gene, but does not have that genetic disease related to the abnormal gene. And this disconnect in language is causing us tremendous trouble, because in the rest of medicine, when we say carrier, we are conveying that there is no disease condition. Whereas in hemophilia, we understand that she could, in fact, have bleeding, and in fact, many do. So hemophilia carriers are often symptomatic with bleeding. We know this from high BAT scores. We know this from radiology of joints. We know that they have excessive mucocutaneous bleeding, which isn't the textbook for hemophilia pattern. And we also know that bleeding is only weakly associated with the factor levels. And remember, we define disease severity based upon these levels, and that's one of the problems we have with these definitions. So I think we have an issue with calling people carriers, but we're stuck with that right now. So I'm calling them genetic carriers while we all work it out. And I think that, I'm just going to speed this up a little, that what we have is we need to revisit how we view the family. And this is important when we talk about reproduction and pregnancy, is that we have a mother who may or may not have the condition herself. And we need to consider that because she has a risk of bleeding, and pregnancy and delivery is a big bleeding disorder, bleeding challenge. In addition to that, she has infants, she has fetus that may be at risk. Certainly half of her sons will be at risk to have hemophilia, and we need to not forget that she can deliver a girl who also may be affected. So we know that we're undercounting everybody. For every male with hemophilia, there's over 2.5 females at risk and 1.5 genetic carriers that we are definitely missing if you look at our numbers in clinic. So let's talk about genetic testing now that we've sort of talked about genetics. So the genotype is a useful clinical piece of information. It informs reproductive planning, that you understand what your genetic makeup is, pregnancy and neonatal management, because we understand the risk of the mother and the baby. It informs future risk of inhibitor formation in the baby. And sometimes we can use it, often we can use it to predict how severely affected the baby will be by hemophilia. In addition to that, it's a really useful piece of information if we're ever going to understand this better and to do research to understand what's the mechanism that's causing all this, because the levels clearly aren't the whole thing. The yield of genetic testing is generally very high. Genotyping needs to be done in an experienced lab that knows these genes. The genetics are complicated, but it's high yield. And for example, we have the most numbers in hemophilia A and B. 98 to 99% of patients have an identifiable variant that you can find. And essentially 100% of people can have something informative that tells you what's the parental origin of the allele. So it's a really useful thing for reproductive planning. So there's a couple recent papers out that related to hemophilia A and B that I feel can extrapolate to these other bleeding disorders. In Lebeck et al. Recent Blood How I Treat paper, ideally all potential carriers undergo genetic testing to confirm the diagnosis of hemophilia and to establish the causative mutation. Every individual has their own right to determine their own genotype. It's really critical. And so in addition, some people have 2 genotypes and they didn't know, which really changes the landscape of what we think the risks are to the baby and helps us also better understand the mom. So the methods of prenatal testing and assessments. So if it's an X chromosome disorder, so hemophilia A and B, the fetal sex can help you. We can do PCR early on in pregnancy. Ultrasound can also predict sex with pretty good accuracy. Remember, 50% of males will inherit hemophilia and 50% of females will inherit the risk for hemophilia. It's usually much milder. So when it comes to informing the route of delivery, which we're going to talk about in a little bit, this is a really helpful piece of information because females are generally not likely to inherit severe hemophilia. It certainly can happen, and that's where genetics can be very helpful to predict this. But most female infants are at low risk to have bleeding at birth. Then we can also do genetic testing. We need to get the DNA sample from the baby. Right now, it's chorionic villus sampling, which is done 10 to 14 weeks gestation, amniocentesis a little bit later. That's the most common, at least in our laboratory. And hopefully soon we can have non-invasive maternal testing transition into our bleeding disorder clinics. Part of the challenge here is the complicated genetics that causes hemophilia. So what happens in mom during pregnancy? Well, in a healthy pregnancy, factor levels are often changing. So some factors go really high. Von Willebrand factor goes high, factor VIII, fibrinogen. And some factors don't change so much. You know, for example, a factor IX that causes hemophilia, if you're low, it causes hemophilia B, not so much. And the other factors that are on the other side of clotting also change. So basically everything's shifting towards clots and away from bleeding in a pregnancy that's not affected by a bleeding disorder. But this is some data from one of our papers. Even though you have a marked increase in factor levels, look at the red line, that's von Willebrand factor relative to her own baseline. The green line is factor VIII. And it goes up quite a lot, but it does not go up as high as von Willebrand factor. So even factor levels that increase, they don't all behave the same. And we really don't know that much more about why, but we think it is important relative to what those molecules are doing to stop bleeding. So hemophilia and most rare bleeding disorders tolerate pregnancy itself pretty well. Usually not that common that there's much antenatal bleeding. There are a few exceptions. There are some dysfibronogenemias and some factor 13 deficient patients. It probably depends on what genotype they have that have trouble with miscarriages. And in those cases, we're often talking about prophylaxis during the pregnancy in order to help them maintain the pregnancy. Factor levels in thresholding and bleeding disorders is a really controversial area. And I'm going to call it thresholding because it's what number do we think we need to treat at because we think the risk is too high for bleeding. And I've put some levels here that are in some pretty much several recent reviews. I have to say at the bottom, it's my opinion, these cutoffs may be too conservative, in part because we know the factor levels don't correlate great with bleeding. So the factor levels, using the factor level to inform when you treat is very hard. And also, these are all generally factor levels that are used to treat for a moderate hemostasis challenge, not in pregnancy, which I think sometimes doesn't correlate to the true bleeding risk that delivery confers. So important to know that factor VIII levels in many, but not all patients with hemophilia A will go up, but they are never as high as a normal person. At best, they reach the very low end of the normal range. Factor IX levels aren't going up. And then people generally say, well, we should treat if they're under 50. And again, in a normal pregnancy, factor VIII is near 200. So that's nowhere near what a normal pregnancy is doing. And then the other rare bleeding disorders, there's no data. These treatment levels are pretty similar to non-pregnant bleeding disorder recommendations. And I think it's because we just don't have data either way to support a difference. What we do know is that patients are at increased risk for postpartum hemorrhage after delivery. So the general population is thought to have a postpartum hemorrhage rate of about 19%. And we know it's higher in inherited bleeding disorders, higher primary bleeding, which is the first 24 hours, or secondary bleeding, postpartum hemorrhage, which is after the first 24 hours. And that can go on for weeks. But we know that the risk is high even with care. So what we're doing isn't enough. We know most about this in von Willebrand disease, but we also know in hemophilia A, it's true in all of the bleeding disorders that we're probably not doing enough because they still have increased risk of postpartum hemorrhage, even when we think we're adequately treating them. It's hard because we can't just put everybody together in one bucket. The mechanisms of bleeding are different between every rare disorder. So the result of this is we know there's an increased risk for bleeding, but there's not a bunch of studies to go write those papers and get that evidence to say, here in the guideline, we're going to have a high level of evidence to make a recommendation. All of the guidance is really based upon expert opinion level evidence. And in reality, there's no universal treatment plan. And so it's really important for the patient and the provider to recognize that every treatment plan needs to be individualized for lots of reasons. There's different diagnoses, there's different factor levels, and we need to know what her bleeding history is because we know the levels aren't super great predictors, but they're all we've got to measure and how much drug we gave and where we started. And then there's different local resources to support pregnancy and delivery, and also a neonate that might be affected by bleeding. And there's different local practices around what do we do for anesthesia, who feels what's a great indication for C-section, what's the resourcing that's needed. There's different personal expectations around birth, maybe from the family, maybe from prior experience, and there's different cultural practices. And one of those is conversations around circumcision, for example. These are things that are important and they need to be addressed while everything's calm. And hopefully before the third trimester, but at least in the mid-third trimester, everyone needs to be on board. We need to have all of the disciplines. We need to have the hematologist, we need to have the obstetrician, we need to have the pharmacy, we need to have the blood bank, and we need to have the neonatologist. Everyone needs to be on board for what the plan is. And most importantly, the patient needs to be on board. And we need to have the lab there because we most often want to be monitoring factor levels in patients who are really high risk, and especially for doing treatment. And this plan for prophylaxis usually involves tranexamic acid. It's effective for postpartum hemorrhage in non-bleeding disorder patients, and unless there's a reason not to use it, we are recommending it if we have a patient at risk. And then treatment to increase factor levels is diagnosis specific. Briefly on anesthesia. One thing about being a hematologist is I'm not the person at the bedside who's making the decision about whether or not we're administering anesthesia. It is really common practice to offer neuraxial anesthesia, which is an epidural or spinal, for pain relief, for vaginal, for labor, for vaginal delivery, but also spinal anesthesia is really common for C-section. So these are conversations to have in advance because some of those C-sections are not in the plan. They're being done because something has happened and it's time to make sure that we have a safe outcome for mom and baby. So it's good to have a consensus beforehand, anesthesia consults beforehand, and to recognize also the anesthesiologist who made that plan may not be the one at the bedside. And we need to trust that we have providers who are comfortable with what they're doing. We don't want people operating outside their comfort level because then things just tend not to go as well. I personally consult in 2 large hospital practices, one of which thinks epidurals and spinals are the bee's knees. Everybody's being offered them and they have no issues with them. And I have another hospital practice that really prefers general anesthesia. The first hospital practice doesn't because they think because we know it increases the risk of uterine atony. So each place has seen the same data, the same patients. They have huge volume tertiary care centers and come to different conclusions. And until we have a large body of evidence, it's going to be hard to get beyond, here's what my expertise is, here's what expert level guidance is, and we're gonna do the best we can for everyone to have a good outcome. I do not restrict neuraxial anesthesia if I feel that I know what the bleeding disorder is and I feel like I have a treatment that can correct that bleeding disorder. Important to consider is there's more than one patient. There's at least 2 patients, maybe more, because we have a fetus. And so the status of that potentially affected infant is really important in where she's going to deliver. So we need to have, if we think that we have an infant at risk to have severe bleeding disorder, we want to be in a facility that has the ability to take care of any kind of complication that might happen in an infant who has hemophilia or another severe rare bleeding disorder. We know the most about severe hemophilia A, and we know that this poses increased risk for intracranial hemorrhage to 2.5%. That's a head bleed. And that is the reason moms who are carrying an infant that it's known or suspected to be at risk for severe hemophilia A are much more likely to be recommended to have a C-section. If the infant's not at risk to have a severe bleeding disorder, our general perception is that the route of delivery should be based upon obstetrical indications because that risk of bleeding doesn't seem to be elevated. But again, not tons of data, but that's our general practice. For all deliveries, our intention though is to reduce invasive procedures that could cause trauma to mom's body or baby. So we try to avoid fetal blood sampling. We try to avoid assisted vaginal deliveries, like not a vacuum or forceps, unless it's an emergency. So that does mean there's a lower threshold to go to C-section. I think C-section rates are a little bit higher because they're trying to make sure they're not causing these traumas, and certainly to avoid elective episiotomy, which can cause a lot of bleeding. And I'm going to wrap up here with this most recent study, which I was so pleased to see, because it highlights some questions we've had. And also, I'm pretty sure we haven't talked about it in this forum because it was published this year, and really what the challenges are. So again, using hemophilia A as a representation, which isn't completely fair, but also the best we've got for these other rare bleeding disorders. So with this new study, it's a retrospective review of factor levels and bleeding and genotype in 52 female carriers throughout their pregnancy. And interestingly, what you can see here is that they've colored in whether or not the mom was a carrier for a mild hemophilia, a moderate hemophilia, or severe hemophilia, to look to see maybe that matters. It seems like it could have mattered, but they found there's no difference in the levels between the carriers of mild, moderate, or severe hemophilia A. So you can see the levels are a little bit all over the place in every category, which is what we see elsewhere. They go up as we see, and then they come back down. And the average third trimester levels were at the very low end of normal, and normal pregnancy is usually in the 200s. They wrote the normal range for their population. And interestingly, though, they did note that there was one kind of area of the gene, if that's where the genetic change was, where the levels really didn't go up much at all, which were gene changes in the A1 domain. So that was pretty interesting. So looking at postpartum bleeding, again, the definitions of postpartum bleeding are kind of constantly changing. Now I think we generally consider it to be more than 1,000 milliliters. This cutoff gave you greater than 500, and then they called it severe postpartum hemorrhage if it was greater than 1,000. And you can see the estimated blood loss here, which is 400, but the range is really wide. And then 42% of patients had postpartum hemorrhage by this definition, which with compared to the population using that same definition was quite elevated. The population was 18%. And then severe postpartum hemorrhage, 7.1% of these women had bled more than a liter. And interesting to me here, remember, the levels were not different by genotype. There was a difference apparently by genotype about who had the most bleeding. So the carriers of a severe hemophilia genotype bled a little over half the time, had postpartum hemorrhage, while the carriers of a mild hemophilia genotype still elevated, but about half that, which really suggests there's something going on about the genotype that we're not seeing in the levels, but are seeing in the bleeding. That's consistent again with what we've seen before, although much more work would be needed. This is one study. And then the factor levels were no different between those with and without postpartum hemorrhage. Again, we're given the stink eye to the levels, and you can see they really aren't. The baseline postpartum hemorrhage group 70, no postpartum hemorrhage 76, and then before delivery 152 versus 141. These are not different. So I think there's a real need for research so that we can we're doing the best we can based on our experience, taking care of patients who have hemophilia and who are genetic carriers of hemophilia, to make sure that we get the best possible outcome for mom and her baby. But we really have so many unknowns, and what's the role of the genotype? We don't know what's the role of being an X-linked disorder versus one of these other rare bleeding disorders that's on an autosome. Lots of questions around the factor activity not correlating with the bleeding. And then undoubtedly there's other modifiers that are genetic or environmental, and we're going to say event-driven here. Very similar to Judy's talk, there's a lot of anatomy going on where one of the most common causes of postpartum hemorrhage is uterine atony. Well, if you have uterine atony and you combine that with a bleeding disorder, you're probably bleeding more. So with that, I want to say thank you very much. And I'm hoping we just seeded the cloud to have a good conversation, and I'm looking forward to taking your questions. So are we reading the questions?
I'm sorry.
Hi, Patrice.
Hi, Patrice. That was awesome. That was awesome, Dr. Johnson. That was great.
There's been lots of.
I was so distracted in the middle, I almost forgot to come on.
There's been lots of conversation, and the questions are, many of them are very specific and in-depth, so I'm not quite sure how to frame them.
Well, I was looking at a number of the comments in the chat, and thank you all for being so engaged. And one of the things I noticed is that some people made a comment, so, well, I have taken these hormones before, and sometimes they work for me, but as soon as I stopped them, I started bleeding. Or sometimes I've had to use 3 or 4 different hormone combinations to control my bleeding. And I'm going to validate the fact that for so many of our patients, it's a really individual, personalized type of medicine that we have to practice, just like we can't correlate sometimes your levels to what's actually going to happen and how much you bleed. When we use hormones, for some women, they work, just one is fantastic and others need a combination. So in general, the progesterone is what keeps the lining really thin, and giving it continuously means you don't bleed. But sometimes using something for a long period of time, like progesterone, it can make the lining so thin it becomes fragile. So you have to add back a little estrogen to help stabilize the lining of the uterus. It's a little bit of back and forth. For women who have taken birth control pills and it has controlled their bleeding, when they stop the pills, their uterus is going to go back to doing what it was going to do to begin with. So that if your birth control pills have controlled the heavy bleeding for a while, and you're not trying to get pregnant, there is no reason to stop it. There's very good evidence to show that if you take the pill for even a decade or more, like I did, it can actually, I have no problem admitting that publicly, it can actually prevent uterine cancer because it keeps you from growing a lining, so it prevents endometrial cancer, and can even prevent ovarian cancer. So I wouldn't be afraid to try these different things, or if you have a younger daughter who's in adolescence who's bleeding, and the pill's working well to control her bleeding, you don't need to stop it. But different medicines work differently for different people, and sometimes we need a combination of hormones plus tranexamic acid to be able to control bleeding as well. We have this armamentarium we have to pull from the shelf. It's kind of like cooking. You need to find exactly the right thing that works for you.
Yeah, I'm going to make a comment too. One thing that's really lovely is to find a good GYN who works together with us in the bleeding disorder clinic, because it's really a combination approach. And especially helpful so that patient's hearing the same stuff and is participating in the same way, because what's an acceptable side effect for benefit for one patient isn't acceptable for another patient. And it really is, in my mind, how much is your life being disrupted by what's going on? So if the side effect, maybe we stopped your bleeding, but we made you so miserable, you had trouble getting out of bed, that's not okay. We need to try something else. So, and the other thing is, I'm going to translate from von Willebrand disease, which is where we are realizing it first, we've really underutilized prophylaxis for the bleeding disorder itself. And I think it's because it's IV. And I would like to say, if it was a male with hemophilia, we would have no problem putting them on an IV prophylactic medication, and we should not have that be a barrier to treating female menstruation. So it's certainly good to go with hormonal therapies, whether they're systemic or whether they're locally delivered from a Mirena or another hormonal IUD, which have been, in my experience, usually pretty great, but not for everybody.
Right.
And moving on to, we use tranexamic acid in combination with hormones really commonly. No matter how many times it flags it in our pharmacy thing, we say, no, we override it because we know it's great. And I'm not worried.
I want to comment on that. You're so right, because every patient who goes to the pharmacy for their birth control pills and their tranexamic acid gets told by the pharmacist, you're going to get this big blood clot. And we've got really good data out there to show that you can use them both safely together. So tranexamic acid keeps the clot that your poor little body has bothered to make intact, which is great. It doesn't make you make new clots. It just keeps the ones that are there, which you need. And when you have a bleeding disorder, you need so desperately just to stay there. So it's totally safe. It doesn't increase your risk to clot at all. And birth control pills, while we know they increase your clotting factors some, when you have a bleeding disorder, you're missing some of those clotting factors. It's not really an issue. So the two can definitely be used safely together, but it takes a lot of confidence for a patient or a woman to say to the pharmacist, look, I know you're wrong. You just got to do it. It's okay. And if you have a gynecologist who's a little nervous about that, I agree with Dr. Johnson. See if you can find a clinic where you've got both a gynecologist and a hematologist working together. We had one in Orlando where I just was. We're getting our one going in Miami. You've got Dr. Ames Olschlager up there at UW, in the Pete's Gyne world, I know, and some other people. So these clinics are really popping up all over the country, and they're awesome because we're a team to help.
And we can be partners anywhere. So our hemophilia treatment center serves the entire state of Washington. So it's not plausible that your GYN is in Seattle and you're seeing my clinic. And that's true for lots of places in America. You know what? Phone calls work great. We all should be working together for you, and you should be advocating for yourself, but it's our job to advocate for you too. So, and if you need to try 3 different or 4 different formulations of that pill before you find the right one, and we've all had that experience where it didn't work, and then, we found it. It was a miracle. And then sometimes you're like, well, that's enough trying that. I need to move on to something else. And we have conversations about, are you planning to have more babies or not, or any babies at all? And I think we just want to say that it's not okay to put up with excessive bleeding. Like the iron deficiency talk we had earlier, we need to make sure you're iron deficient. But if you're iron deficient, we haven't done a good job of controlling your bleeding. And we need to be doing that That is an essential thing. That is like, our job is to help people lead their lives. And this is a major barrier to doing that. And I'm kind of mad about it.
Okay.
There was a question earlier about Mirena.
Yeah, there was a question, can you use additional hormones when you have a Mirena? Absolutely, you can. So what I use with Mirena a lot of times, because Mirena is straight progesterone inside the lining of the uterus, is I'm a big fan of a medicine called norethindrone, Norethindrone. It's not a birth control pill. It's also technically a progesterone that has a little bit of conversion to estrogen. And it's amazing at stabilizing the lining of the uterus. I use it in my young patients, and I use it in patients with Mirena. And it's definitely safe to use on top of it. It doesn't interfere with how well the Mirena works. The other thing you can use is you can use tranexamic acid or Amicar. I've used both with my patients who've had bleeding with the Mirena. The bleeding with Mirenas tend to be worse in the first few months after they're inserted. If you've had a Mirena, though, that's been working awesome, and all of a sudden you're bleeding, I want you to think about a couple things. One, could you have a STI? Did a little chlamydia get into your uterus? So make sure that you get checked for that. Two, did the Mirena slip down a little bit low into your cervix? About 5% of IUDs can be pushed out by your uterus. Your uterus goes, I don't think so, and pushes it down. Double check to make sure your IUD is in a good place. Sorry, I'm GYN, I make lots of noises, but it's okay. You know, you want to make sure that your IUD is in a good place. Don't just attribute it to your bleeding disorder. And I think that's the theme of my talk, is that women with bleeding disorders also have, as we've seen on here, fibroids, CIN, dysplasia. Make sure that you take care of the girl parts or the female organs. And Dr. Johnson, I love the way you use gender neutral data. You know, we have transgender patients who happen to have a uterus. You know, make sure that if you have a uterus, you're addressing these issues.
I have a comment too, is not to forget that the cervix really likes to bleed in some of these bleeding disorders. Mm-hmm. So I'm sure that community gynecologist thinks that all the IUDs are not a hemorrhagic risk, but I can certainly tell you that we want to know you're having your IUD placed, and we will write a treatment plan for that IUD placement, because not only is there a little manipulation there, and just some bleeding disorders just will not put up with that, and you're going to have a lot of bleeding that sometimes gets you into real trouble. So we want to anticipate that. And I like to prophylactically treat for a period of time after IUD placement, exactly as you said, because we know that the Mirena can, in some people, just cause, well, let's just plan for that. Let's just plan that there's going to be bleeding. We're going to have this period of time before we get that nice effect of having placed it. And also, I guess, can you comment? I've had patients where it's kind of worn off before 5 years, that year 4. So if you've checked that it's not malposition, you don't have an infection, there's no anatomic thing, well, just consider it's time to replace it. Just because the FDA approved it for 5 years doesn't mean it works that way for everybody. So
I couldn't agree more. And I've changed them out, and they've done that. And I agree also with the, you know, prophylaxis, using before insertion, tranexamic acid, being careful. It's really good that if you have an IUD placed, that you do with somebody used to working with patients with bleeding disorders. We have some tricks.
Not to use the
vernacular. There's a grasper that we use on your cervix to put the IUD in to hold it steady, which is important. We have some that are gentler. The other thing that I do is I actually do a cervical block that's got some epinephrine in, so people don't bleed and I don't traumatize the cervix. And there are some patients with Glansmann's or some other disorders that are more significant, that I'll put my IUDs in the operating room, not because they need anesthesia, but because I want a totally controlled environment. And that's pretty rare. But let's say I've got a 12, 13-year-old who's never been sexually active, but we've tried other things, and for whatever reason, she can't tolerate the hormones. You can use these for control of bleeding, even in young patients, but no, maybe she doesn't want us to do that in the office. So we have different things that we can do to help make it comfortable and safe for everybody, for sure.
We've reached the end of our time, and this has been such an amazing session. I'm so glad we have it recorded. And I wanted to tell folks in the audience that we will eventually be able to upload the recordings to our YouTube page for Hemophilia Foundation of Michigan, and you'll be able to see them. So we've got you on tape, and thank you both so much. We love having you here, and you've given Dr. Sidonio the perfect opening to talk about prophy. So it's great timing.
Right.
So thank you so much.
You're so welcome. Great to be here. Nice to meet you. Take care. Bye.